have a session on a very common complaint which is neglected, not because we don't have a problem. Neglect होती है डर की वजह से. There is pain, लेकिन एक उस पेन के इलाज को लेके इतना एक डर का माहौल है कि हम सही समय पे उसका इलाज नहीं पिकअप करते, और वो शिकायत है घुटनों में दर्द की. It is not aging, it is a problem. Before it becomes a disease, solve your problem. It is possible. And to answer your questions, we have one of the most illustrious figures in orthopedics, a doyen of the subject, most respected academician, a great human being, and a philanthropist, not only as a doctor, but as a human being. It is my proud privilege to invite Professor S S Jha, who has enormous number of accolades. And I must say, हमारी एक ही मुलाकात में, it was as though we were looking for each other. And it's a great pleasure, sir, to have you over as our speaker today. It is indeed a matter of great pride for all of us to have such an illustrious person as our speaker. Welcome, sir, all the way from Patna. Thank you so much.
Thank you very much. I'm talking about a topic for which there is already an alertness in the audience.
Very nice.
So to start with, I will like to talk about joint pain in elderly and can prompt attention come out with better outcomes, including maybe deferring the joint replacement. Well, so joint pain, they come in various denominations, and as you have rightly, Dr. Grewal pointed out, that if it concerns the knee, is it one knee or both knees? But while making a differential diagnosis, we have to see that more than two joints, maybe many joints are involved, and all of us are aware that these could be patients like this who have rheumatoid arthritis. And rheumatoid arthritis patients also require joint replacement. Well, this is one of the ladies who have rheumatoid arthritis deformity in the hand. अब अगर हम पूछें कि मस्कुलोस्केलेटल डिसऑर्डर पूरे पॉपुलेशन में किस तरह से है, एज फार एज क्लिनिशियन के ओपीडी में अगर हम देखें तो 5 से 10 ऐसे लोग जो हमारे क्लिनिक में आते हैं, उसमें कम से कम एक जीपी के क्लिनिक में, आई मीन टू से कम 1 out of 5 to 10 they have musculoskeletal disorder. 2/3 of them are aged less than 65, and the reasons are osteoarthritis, pain in back, gout, fibromyalgia, tendinitis, and bursitis. Well, arthritis and back pain, they are the leading cause of chronic disability, and it is only second leading cause of acute disability behind respiratory illness. Well, talking about osteoarthritis, what we have to be aware of regarding the pathogenesis of osteoarthritis, that we used to say कि हमारा उम्र हो गया, हम इतना चलते हैं, बाल सफ़ेद हो गए. So maybe ये एजिंग प्रोसेस के वजह से, या उसको लोगों ने कहना शुरू किया डीजेनरेटिव ऑस्टियोआर्थराइटिस. लेकिन ऐसा लगा पिछले कई वर्षों से, अब तो कहेंगे 25 वर्ष से ज़्यादा से, कि इन्फ्लेमेशन इसका एक कारण है. सो we have now switched over to inflammatory theory in the pathogenesis. In fact, it was 1990 जब मॉलिक्यूलर बायोलॉजी में प्रोग्रेस हुआ और ये इन्फ्लेमेटरी थ्योरी डिस्कवर हुआ, जिसमें पाया गया कि कॉन्ड्रोसाइट्स में मैट्रिक्स मेटालोप्रोटीनेजेस वो रिलीज होते हैं, और वो साइटोकाइंस जैसे कि प्रोस्टाग्लैंडिन है, उनके कारण बढ़ते हैं और वो डैमेज करते हैं कार्टिलेज को। ये इस बात को फिर से प्रूव किया गया इमेजिंग स्टडीज में कि इन्फ्लामेशन ही कारण है ऑस्टियोआर्थराइटिस का। अब एक बात जो हमें समझने की आवश्यकता है कि जोड़ में हम सबों को पता है, हम सब डॉक्टर हैं, कि साइनोवियल टिश्यू हैं, तो इन्फ्लामेशन के चलते साइनोवाइटिस होता है और कहते हैं कि साइनोवाइटिस के कारण ही ऑस्टियोआर्थराइटिस का ड्राइविंग फोर्स अपीयर करता है। इन सारे लॉजिस्टिक्स के साइंटिफिक प्रूफ के बावजूद 2000 ईस्वी तक इसको लोगों ने एक्सेप्ट नहीं किया, लेकिन there were arguments in favor of inflammatory theory, and they were substantiated that low-grade inflammation is induced by metabolic syndrome, innate immunity, and inflammaging. हम मेटाबॉलिक सिंड्रोम के बारे में जानना चाहते हैं। कहते ना हम लोग हमेशा एल्डरली एज में क्या कोमॉर्बिड कंडीशंस हैं, तो जैसे मेटाबॉलिक सिंड्रोम में देयर आर क्लस्टर ऑफ कंडीशन either occurring together or maybe singly. So there is increased risk of developing type 2 diabetes, heart disease, stroke, or maybe all of them. So there are metabolic factors which include abdominal obesity, high blood pressure, impaired fasting glucose, high triglyceride level, and low HDL cholesterol level. Now, this word during the last Choupal symposium, we had talked about inflammaging. As the name itself suggests that with aging, there is an inherent inclination towards developing inflammation in the system.
Wow,
So,
amazing. Wow, what a
inflammaging, right. So with age. So geriatric population is not immune, rather it is in the geriatric population that most of us develop inflammaging. This was coined in 2000 by Francesi. So aging process has chronic, progressive, pro-inflammatory phenotype. And
Wow.
technically, I will not like to enumerate all of them, but then majority of us know that interleukin 1, 6, 18, microRNA, TNF alpha, they are important cytokines which are responsible. So during inflammaging, what happens? Our body gets collected or damaged cell debris, so they have to be removed. There are irritants or pathogens. So during the process of removal of this cell debris, irritants or pathogens, this foreplay results into systemic effects. And that is the reason, अगर आपका हीमोग्लोबिन 50वें साल 55वें साल में 100% हुआ करता था, when you are aged, it is still not 100%. So anemia is a feature. Your bones are not as strong, osteoporosis, and as one of the questions coined, how stable or unstable you are while you are walking. So sarcopenia is that muscle weakness which is an outcome of inflammation. There can be neuronal damage or genesis of neurons. There could be even insulin resistance, and the mitochondrial function and biogenesis are also affected. Friends, in the population surrounding us, we will find that there are many obese patients. Have we ever thought of that this is a reason why osteoarthritis and osteoporosis become common? And it is not the subcutaneous fat. Most importantly, it is the visceral adipose tissue, and then the local fat pads. So all of them, they secrete adipokine, and finally they result into osteoporosis and osteoarthritis.
Beautiful.
Friends, when we get pain in the joint, we keep on talking to maybe either a neighbor or a friend she says, the patient, I felt so horrible this morning, I decided to kill myself by taking 100 painkillers. Then the natural question is, so what happened? And she says, after taking only 2 tablets, I got the relief. So nothing is there which cannot get at least a temporary relief. And I will not like to read the whole lines when a doctor said doctor. So we in India particularly, and maybe even abroad, we have too many advices, but we should take each one of them with a pinch of salt, and we must reach a specialist. Now, if the joint pain is only one, very important question raised, it is only one joint. So, rheumatoid arthritis, all of us know, is a polyarticular disease, but this disease also can start with a monoarticular onset. And the most important conditions for monoarticular ones are gout, osteoarthritis, and septic arthritis. Friends, if there is a effusion in the joint, this must be seen that aspiration is done, and you must see that it is at least not a case of joint infection. So must aspirate a joint. Now, if we aspirate the synovial fluid, the content should have more than 2000 WBC cells for acute monoarticular arthritis. Assume infection if it is more than 2000 until proved otherwise. So the joint must get aspirated. This is one of the joints which is being aspirated. Now, if it is a polyarticular, so how do we say definition of polyarticular? There has to be swelling, tenderness, warmth in more than 4 joints. Possy or oligoarticular, 2 to 4 joints only are involved. But when it is polyarthralgia, pain is there in only more than 4 joints. Without demonstrable inflammation, diffuse ache and pain, there is poor localization. Well, now here is a patient. So how do we proceed? Patient's history, physical examination, lab test for early diagnosis, radiographic evidence, ultrasound, and joint fluid examination. I always keep on saying that clinical history is so very important that the clinician should talk to the patient till the patient gives his or her diagnosis. And regular follow-up is equally so important. Now, these are the various features. I will not go into the detail for non-inflammatory, inflammatory, and septic arthritis. So this is one of the routine osteoarthritis patient in which the patient has deformity in the knee. These are the osteoarthritis patient's X-ray. By looking at the X-ray, we can say he or she belongs to grade 1. Osteoarthritis of the knee, can joint replacement be deferred, is the topic of this evening. And this is one of the clinical presentation of osteoarthritis, which we have seen all these photographs. Now, I want to take you through one of the patients. Now, I will be showing you some of the X-rays. 71 years lady with rheumatoid arthritis and secondary osteoarthritis. She was a housewife. She was operated at the age of 59 years in 2012. This is the X-ray where you can look at the osteophytes. This is the osteophyte. The joint damage, you can see they are almost kissing each other. Virtually there is no joint space. So 2012, these are preoperative X-rays. She was operated in December 2012. and she was operated by a very famous surgeon in Mumbai, and she did well for almost 4 years. But see, if we have started looking at the joint, only 10 days post-operative, what we find is that this one is little eccentrically placed. And now see, this has started moving further
Oh,
in lateral view, but now see, this has almost started touching the opposite cortex, the joint, and the whole thing is sinking inside the tibia. Same, the bilateral knee joint replacement was done, and lo and behold, what happened? That she had history of injury, developed thigh pain, and was not walking from December 21st.
true.
And it was only later in April 24 that a fracture was discovered in the neck region of the femur, for which she underwent finally in April 2004. So I have gone through this case report only to highlight that the patient must be fit enough. When I say fit enough, it is not only the systemic fitness, the cardiac fitness or respiratory fitness, the bones also must be strong enough to hold the joint in place. So the patient must undergo a treatment for osteoporosis before it is done. So what I mean to say, management of osteoarthritis, have we been getting it right? Definitely no. So management of osteoarthritis now, knee joint, so time is now with intervention of Dr. Grewal that we can get them right. So whatever treatment has been available, either they have not been effective in either slowing the disease or arresting the disease. In beginning, whenever a joint pain takes place in the knee joint, it looks like to be indolent, but it becomes clinically relevant later when non-immune and immune-mediated inflammatory events begin to dominate. Well, I have just now talked about the inflammatory theory and all these inflammazing things. Now, osteoarthritis, the definition itself got established in 2015. Before that, there was a lot of confusion. So it said that there has to be anatomical and physiological derangements both ways, leading to degradation, bone remodeling, osteophyte formation, joint inflammation, and loss of normal joint function.
Beautiful.
And friends, we get heart failure. Similarly, we say osteoarthritis is a synovial joint failure. And the processes, they start in the surface, articular cartilage, which gets fibrillated, osteophytes form. Subchondral bone sclerosis is the key place where changes do take place. There is chronic inflammatory response, and this finally leads to synovial joint failure. I will not like you to draw into all these diagrams, only meaning thereby that the articular cartilage surface and the synovial lining cells, they finally produce osteoarthritis. Well, if somebody wants to know what is the status of my joint, it is not the MRI, routine MRI, which is to be advised. We have to look into the health or thickness of the articular cartilage. So, degree of joint space narrowing will have to be studied, and it has been shown that it is positively associated with subsequent total knee replacement within 15 years. So what is the formula? For each 1% rate of tibial cartilage loss, there is 20% increased risk of undergoing total knee arthroplasty within 4 years.
Wow.
So The investigation that we should look for is MR cartogram. It assesses articular cartilage integrity. Well, there are now some biomarkers also, because ordinary X-ray are insensitive to early changes within the cartilage and bone. This is for grade 1, but grade 2, 3, 4, they may not reflect the synovial pathology. So the biochemical markers are matrix protein, COMP, which is known as COMP, or urinary CTX2 or hyaluronan. So let's talk about how do we manage. So initiation of emerging specific therapy to forestall or decelerate. So once the joint degeneration gets decelerated, progression of osteoarthritis to synovial joint failure will not take place. So that is the desirable. Now, what are the desirable drugs that are effective with us? So we have to fix our target. Do we want to target the cartilage or the subchondral bone or the inflammatory process or the pain process or the metabolic syndrome or targeting the senescence and aging? Invariably, more than 2 or 3 things will have to be targeted. Now,
Yes.
these are the drugs which target cartilage and knee osteoarthritis. Sprefermin is one drug regarding which we will be talking later. It helps in regeneration of the cartilage. Now, targeting the inflammatory process, anakinra is a biologic which antagonizes IL-1, and there are other targets, they are also helpful. So targeting osteoporosis, as I was telling you, also becomes very important. So inhibition of osteoclast activity. Zoledronic acid is so very important. It has to be given in infusion at least once a year, but at the same time, oral drugs like Risodronate, and the best one is still not available in India is third generation disodium zoledronic tetrahydrate. This also is given intravenously, almost costs you 30,000 rupees, but this is a best drug. Now, cathepsin K inhibitor that inhibits bone degradation. Since there is an inflammation, the rheumatologist thought that maybe anti-inflammatories or biologics that we are using for treatment of rheumatoid will be helpful. No, that is not. So, not effective in osteoarthritis is all the biologics like adalimumab, etanercept, infliximab, and also hydroxychloroquine is not effective. But hydroxychloroquine is effective in hand osteoarthritis, and all these biologics are also effective in erosive hand osteoarthritis. The other drugs that we keep on prescribing is duloxetine for osteoarthritis management, then oral or systemic NSAID, and when we talk about NSAID, capsaicin, mircha. Mircha ka, there are so many gels available in the market, and even tramadol. Now, oral DMAOD, I have just now talked about cathepsin. It still has not been permitted, but it is in phase 3, and it has produced side effects like stroke, atrial fibrillation, so it has still not got the approval. IL-1, I told you, targets inflammatory process but does not work in osteoarthritis knee, but is effective for hand osteoarthritis. Friends, when I talked about inflammaging, then there are drugs which not only cuts down the inflammation, they make you live longer. So they are the longevity solution. And in very short, I will like to say Rapamycin is one such drug. It is anti-inflammatory, is waiting for longevity regulation in animals and humans, improves survival and health span, especially in animals. So rapamycin, aspirin, and metformin is a very important drug. Even if you don't have diabetes, metformin can be used for longevity solutions and as anti-inflammatory. Now, in the modern management of osteoarthritis, the silver lining lies in two drugs, sulfasalazine and tofacitinib. Tofacitinib have been introduced into the market, and now almost every company comes with this. These are oral drugs, small molecules, and they have been almost abused, not used, rather abused. But this is one drug which can be used effectively in. So what is the novelty of tofacitinib? It increases cellular levels of adenosine and known to have anti-inflammatory activity. Sulfasalazine has three mechanisms: antibacterial, anti-inflammatory, and immunomodulatory. Friends, as far as drugs are concerned, we can directly attack the joint. So intra-articular, novel, non-surgical therapeutic measures could be taken. Intra-articular steroids used to be given. Now there is extended release formulations of synthetic triamcinolone. The drug Gilreta is not available, now available in India, but is being exported from outside. But the other one, triamcinolone hexacetonide, is available in India. It helps in cutting down pain for minimum 3 to 6 months. The other drugs are small molecule inhibitors. They are still in experimental phase 3 trial, but this is a very good drug. Stem cell, the regenerative medicine is there. It is available in India. The drug costs you almost more than 1 lakh of rupees. It has to be given, and it has been found to be effective in grade 2 and 3. Well, gene therapy, which is available in South Korea, goes by the name of Infosa and has a definite role in improvement. Isprefermin is another drug which again is in phase 3 trial, and this is the real disease modifying osteoarthritic drug. The other drugs for intra-articular use, Botox, all of us know, is used for cosmetic, facial lift, etc. Capsaicin, mircha ka intra-articular injection, also works much better, and there are other factors. The hyaluronic acid we are injecting routinely in the joint, and now we have a better local anesthetic like prilocaine. As I had told you earlier, osteoporosis is a common denominator both in osteoarthritis and rheumatoid arthritis. So friends, I would like to conclude that with acceptance of inflammatory theory, the management is focused on targeting subchondral bone, chondrocytes, and the inflammatory processes mainly. Gene therapy and mesenchymal stromal cells, जिसको stem cell therapy कहते हैं. So gene therapy and stem cell therapy have a definite futuristic role, and they are likely to come in a big way. Now, evolution of DMOAD, disease modifying osteoarthritic drug. These three are the best ones, but still have not been approved by FDA. They are in phase 3 trial. And silver lining in oral therapy, as I have just stated, is small molecule tofacitinib and sulfasalazine. Well, friends, there could be a personalized treatment, and we have to better understand that all osteoarthritis are not the same. They could have different phenotyping. So we must also, as I have told you, the inherent osteoporosis must also be treated. Let us not forget the role of physiotherapy, which will be a must. And this I have already told you. So with this, thank you very much. I'm so sorry for taking little more
No,
time.
no, not at all, sir. Not at all. Sir, it was not a presentation. It was music. It was absolute music. And you can stop the sharing, sir.
Right, I will.
The red indicator.
All right.
So it was music, and there was an orchestra, and you were the you were the music master, I think. I think the biggest change, आपने सबने please, a dynamic atom bomb has been blown by Professor Jha. That जो आपको घुटने में दर्द उम्र का तकाजा मानते थे, डिजेनरेशन मानते थे कि तोड़ फोड़ हो गई, उम्र की तोड़ फोड़. He has given the whole change of new theory of inflammation. And managing inflammation can prevent your surgery. I think इससे बड़ा message I'm sharing with you, Professor Jha. It was goosebumps because what you have just done is you have changed my entire mindset. किसी को ये कहना कि घुटने में दर्द है, ऑपरेशन अभी रुक जाओ, पहले तो हम बहाना मारते थे. But what Professor Jha said कि there is an alternate because the theory has changed. What a wonderful presentation. What a wonderful
Right.
presentation.
Thank you very much. Now, I would like to add one thing more.
Sir.
There is a situation in which we say this is a complex joint. When we say complex joint, that means there is not only varus or valgus. There are flexion deformities. So triple subluxation kind of thing is there. And the joint may have laxity also, mediolateral laxity. Now, these patients are likely to fall. They are very severely compromised. So they must undergo joint replacement as quickly as possible.
That's right. So जिस condition में ऐसा नहीं है कि सबके घुटने माफ हो जाएंगे. If the danger of falling is there and instability is high, that person must undergo surgery. Dr. Professor.
Well, madam, I must make it very clear. Baricitinib is a very good drug, but is very specific, not for osteoarthritis, but for rheumatoid arthritis.
Yes, sir. Yes, sir. Of course, it is indicated for patients which tofacitinib doesn't. The patient don't respond to tofacitinib. Baricitinib is being given, and they will respond to it.
Right. And I would like to highlight one thing more.
Sir.
In elderly patients,
sir,
the dose should not reach 11 milligram. You should restrict the dose to 5 milligram alone.
Okay.
Right. Because there are likely to be complications.
Professor Jha, you will agree, ma'am, these are drugs that are to be very selectively used.
Rheumatologists normally use it, sir.
Yes, that's right. Professor Chandra, आप बोलिए, ma'am.
No, it is very extremely well explained thing that we have just heard. In my practice, not that I'm doing much practice, but the cost and availability of these drugs is not very easy.
Yes.
So that I think subsequently government will do something for geriatric patients. The cost should be taken care of, and availability, and they have to go to specific places to get the injection and all. So if that aspect is also looked into, it will be very good.
Professor Jha.
You are very much correct in saying that biologics are costlier drugs. But then biologics are effective in rheumatoid arthritis more. And even for speaking for biologics, madam, I must tell you, etanercept is available. If you negotiate with the company directly, they will make the drug available for 2,000 rupees. And 2,000 rupees is one injection per week. So that way, One of the biologics could be
And
cheaper.
I think Professor Jha, you'll agree, this type of alternates does come as a savior
Yeah.
for
Yeah.
many patients who cannot undergo knee surgery because of
Yeah.
comorbid conditions, but they are suffering in pain. So it is not routinely used. It is probably, Professor Jha, used for patients. Suppose somebody has a heart attack and is not fit for surgery. As he said, it must be fit. So therefore, these are alternates, not as first line alternates.
Yeah.
That's important.
Now,
Yes, Rashmi ji, please. Dr. Rashmi?
Sir, am I audible?
Yes, please go
very
ahead,
much.
Dr. Rashmi.
Okay. Sir, I had my bilateral TKR done about 9 years ago. I'm 70 now. But after hearing Dr. Jha, I'm wondering whether I really needed it or not.
No, but I am very sure once you
Mm.
got it done,
Then you
Yes.
were
your quality of life has definitely improved.
Very much.
That was
Definitely.
one reason why you had gone for it. So
Yes.
your estimation of your quality of life is your individual perception.
that is
Now,
Mm.
I will tell you one story. I sent my own sister to one of my very senior friend in Delhi that go and consult him. My sister was so frustrated. Why did you send me to him? Because he never examined my knee. He only raised his eyebrows and said, when are you interested in getting it done?
Mhm.
So that should not be the attitude.
That's
No,
true.
no, that, sir, but I have a question
Yes,
which
please.
pertains not to osteoarthritis but meniscal tear. Can I ask you,
Yeah,
sir?
sure.
My husband has a medial meniscal tear, posterior horn at the root,
Right.
and he plays table tennis. And sometimes after playing, his knee is very bad. He even gets a cyst at the back of the knee, Baker cyst. And but sometimes it is not so bad. So my question is, does he need meniscal repair or can he wait? Or
As far as the root tear is concerned, it
Hmm.
should have been done in the early stages
Early stage.
alone. Then
Okay.
you can think of repair. Now is not the stage for repair. And what happens? Now we are conscious about these root tears because now we have so many arthroscopists going into the joint. But meniscal, at this age, I think if he is not worse many a times, he can do with regular exercises by quadriceps drill. And as far as that Baker cyst you have said, this unnecessarily draws one's attention. This is a natural phenomena with lesser muscle tone. There is posterior herniation of fluid in the popliteal fossa.
It's the
So,
weakness of the muscle.
right. So mere presence of Baker cyst is no indication for undergoing meniscal surgery or maybe even joint.
So there are some questions on the box.
Please,
Thank you,
please,
sir.
please.
How Ramchandra ji, Gulati ji, how damage to the knee can be prevented? I think the entire presentation was that doctor advised advice for total knee replacement. Oh, somebody, Mr. Gupta, sir.
Don't get guided by your doctor. Look into your constant. How much constant this osteoarthritis is keeping on you. How long you are able to walk. With exercises, you are likely to improve. Is there a deformity? Do you get rest pain? That also becomes very important. Is your knee very unstable?
देखो गुप्ता जी, ऐसा है जो आप कह रहे हैं और 4 डॉक्टरों ने कहा कुछ ना कुछ वजह होगी. आपके प्रोफेशन क्या है?
Retired. Sir.
Retired. So therefore Professor Jha is saying find out कि आप खुद देखिए कि मैं ऑपरेशन हो गया, मेरे लाइफ के अंदर क्या क्या चीजें वो कर पाऊंगा जो कि मैं आज नहीं कर पा रहा, या मेरा तड़फना इतना है कि लाइफ बहुत बदतर हो रखी है. That is the two reasons.
सर एक पेन किलर यदि रोज ले लेता हूँ कॉक्स या पी, देन आई एम कंफर्टेबल.
Are you diabetic?
नो.
No. So if you're not a diabetic, Professor Jha, he should give it a trial of severe lifestyle changes.
But keep your kidney function
Careful.
intermittently evaluated.
क्योंकि आप निकॉक्सिया खा रहे हैं तो अपने
और-
गुर्दे का जरूर ध्यान रखिएगा.
और बेहतर होगा आप खाना ही है तो एसिक्लोफेनेक खाइए, लेस डैमेजिंग टू द किडनी, और ट्रामाडोल खाइए, लेस डैमेजिंग टू द किडनी.
Mr. Rajesh Malhotra says, I get crackling sound when bending the knee.
Right. There is a clicking knee joint or clicking joint. Whenever there is a sound
Movement.
in the joint, no sound in the joint with movement, it is sign, I always say it is sign of good health of the joint. Keep talking to your joint when you are alone.
That's right. So, Gopal, I think आपकी एडवाइस दोबारा सोचिए कि आपकी लाइफ में यही जो डॉक्टर झा कह रहे हैं कि देखिए सर्जरी में आपकी लाइफ के अंदर क्या क्या बदलाव आएंगे.
आप सोशल फंक्शंस में जा पा रहे हैं या नहीं जा पा रहे हैं?
दैट इज इंपॉर्टेंट.
हाँ,
घुटने की वजह से घर कितना रुकना पड़ रहा है. वेरी इंपॉर्टेंट, वेरी इंपॉर्टेंट. सो आई थिंक इन नटशेल, Vinod Shahji, after TKR post surgery is tough, not smooth. Absolutely. That is why Professor Jha is saying that surgery.
no, but
surgery safe will be- Ji, please
I
go
would
ahead.
like to add,
Sir,
there is again, लोग कहेंगे कि नहीं साहब, एक्सरसाइज फिजियोथेरेपिस्ट को लगाऊंगा आपके ऊपर तभी होगा. मेरे ख्याल से थोड़ा हाइप भी है. और सर्जरी के बाद तो उस समय हम लोग इंजेक्शन दे देते हैं जॉइंट में ऐसा कि आपको तो पेन भी नहीं होता. थर्ड डे यू आर अलाउड टू वॉक, यू आर अलाउड टू नेगोशिएट योर स्टेयर्स. So post-operative recovery, in fact, if you were in difficulty, you will feel why I did not get it done earlier.
earlier. आजकल उसकी रिकवरी बहुत अच्छी. देखिए, the question is, if the pain is affecting your quality of life and आपका बाहर जाना नहीं, बहुत घुटने में दर्द है, आज मैं नहीं जा पाऊंगा, you need to consider the alternates जो प्रोफेसर झा ने बताए. अगर वो कामयाब होते हैं तो करिए. लेकिन आज का टॉपिक प्रोफेसर झा से इसलिए इंपॉर्टेंट था कि निराश मत होइए. आप निराश मत होइए कि मैं सर्जरी करा नहीं सकता तो दर्द मेरी जिंदगी का हिस्सा बन गया. डोंट सफर. देयर आर मेनी ऑल्टरनेट्स. दैट इज द मैसेज टुडे. एवरीबडी डज नॉट रिक्वायर सर्जरी. दोज हु रिक्वायर सर्जरी हैव ऑल्टरनेट्स. लेकिन अपनी लाइफ को खराब मत करिए. दैट इज द बिग मैसेज टुडे. घुटने की सर्जरी को लेके जो एक हवा बना रखा है, वो उस हवा में मत रहिए, कराइए. बड़ा आसान सर्जरी है लेकिन सही होना चाहिए. सो आई थिंक फर्स्ट जी गोयल साहब, सबसे बड़ी बात आपने हल्के में कह दी. ये मैसेज प्रोफेसर झा का जो नॉन डॉक्टर्स हैं उनके लिए जरूरी ये है, जैसे आपके लिए, कि आप जाके डॉक्टर से सवाल करिए बराबरी पे कि दी मैं अभी ऑपरेशन नहीं कराना चाहता, मेरे पास क्या ऑल्टरनेट है. आपको बताना ये था.
ये सिचुएशन तो जब होगी जब ऑलरेडी पेन चालू हो गया, जा नहीं सकते, जैसे
उससे
इन्होंने
पहले
अपने
तो-
शिष्यों को भेजा
पहले तो-
और वो कह रहा है कि भाई कब आगो, तो वो बात अलग है. मैं कहता हूँ कोई है ही नहीं, अभी कोई तकलीफ नहीं है.
तो बढ़िया, उन्होंने कहा नहीं अपने घुटनों से बात करा करिए.
मैंने अंतिम स्लाइड दिखाया फिजियोथेरेपी. आप घर में अपने घुटने को स्टैटिक साइकिल खरीद के ले आइए, और आप कुछ नहीं करते तो स्टैटिक साइकिल चलाइए. आप मॉर्निंग वॉक में जाइए, और हम कहते हैं कि थोड़ा ब्रिस्क वॉक करिए, एंड दैट शुड बी हेल्पिंग यू.
That is what I am doing. I am 90. I am even doing gym.
Oh,
Right.
very good.
Right.
Very good. Very
and
good.
take care of your bones. Take
Take care.
milk. Take protein.
enough protein.
So first and foremost, I invite all of you to please give a big hand to Professor Jha
Thank you.
for
Thank
sparing
you.
his time. Thank you so much, Professor Jha.
Right.
And before we conclude, I once again would like to express